This lecture over neurologic progressive degenerative conditions covers Parkinson's disease and myasthenia gravis. We will also touch on Huntington's disease and amyotrophic lateral sclerosis, otherwise known as ALS. Parkinson's disease is a chronic progressive neurodegenerative disorder. The exact cause of Parkinson's is unknown, but it's thought to involve genetics and some environmental aspects. Around 20% of patients with Parkinson's disease have a family history, and this increases with the number of first-degree relatives with this disorder. Parkinson's disease results from destruction of dopamine-secreting neurons within the brain. Patients diagnosed with Parkinson's exhibit three characteristic symptoms. The first is tremors. This causes their writing to trail off toward the end of words. The tremor can involve not just the hand, but also the diaphragm, the tongue, the lips, and the jaw. The tremor is often the first sign that the patient has Parkinson's, and the hand tremor is the most common one. The tremor rarely causes shaking of the head. Rigidity is the second sign. This is increased resistance to passive motion when the limbs go through their range of motion. A specific type of rigidity in Parkinson's patients is known as cogwheel rigidity. This is when the patient exhibits stiff stop and start jerking motions. The third characteristic symptom that Parkinson's patients experience is bradykinesia. Bradykinesia is when there is an evident loss of automatic movements. Automatic movements are things such as blinking of the eyelids, swinging of the arms while walking, the swallowing of saliva, and the self-expression with facial and hand movements. It can involve only one side of the body initially, but then progresses to both sides of the body. Bradykinesia accounts for the patient's stooped posture, their masked face, or what is known as sometimes the deadpan expression. It accounts for the drooling of saliva and the shuffling gait that we see in the Parkinson's patients. And these are all characteristic appearances of that Parkinson's patient, as you see in the image on the slide. Some other non-motor symptoms that the Parkinson's patient generally experiences are depression, anxiety, fatigue, pain, constipation, problems with sleep, and short-term memory loss. Collaborative care of the Parkinson's patient consists of pharmacologic treatments such as anti-Parkinson's drugs known as carbidopa, levodopa, which is brand name Sinemet, and bromocriptine, which is brand named Parladel. Carbidopa levodopa is a drug that increases the dopamine release, and this is generally the first-line treatment for patients with Parkinson's. It's important when patients start on this to monitor for dyskinesia. Bromocriptine is a medication that stimulates the dopamine receptors to actually be more receptive to dopamine. For this medication, it's important to watch for orthostatic hypotension. Anticholinergic drugs such as Artane and Cogentin are also used. These are meant to decrease the activity of acetylcholine. Artane is an antispasmodic drug that helps with the stiffness, tremors, spasms, and the poor muscle control in Parkinson's patients. And Cogentin is used together with other medications to also treat the symptoms of Parkinson's, such as the muscle spasms, the stiffness, and the tremors as well. All of our treatments, our pharmacological treatments, are aimed at correcting the imbalance of the dopamine neurotransmitter. Diagnosis with Parkinson's disease is based solely on the history and the clinical features. There is no firm diagnostic test that can confirm the presence of Parkinson's disease. However, diagnosis is made when at least two of the three characteristics of the classic triad are present, and those are the tremors, the rigidity, and the bradykinesia. Nursing management focuses on maximizing the patient's neurologic function, maintaining their independence in their activities of daily living, and optimizing their psychosocial well-being. Myasthenia gravis is an autoimmune disease characterized by the fluctuating weakness of certain skeletal muscle groups. This disease occurs in both men and women of any race. The peak onset is during the childbearing years for women and around ages 50 to 70 for men. The characteristics of the disease are that with repeated stimulation, the muscles become exhausted and eventually they're unable to contract at all. The hallmark manifestation of myasthenia gravis is fatigability. This means that the muscles become progressively weaker when they're being used, and they improve after periods of rest. This is particularly noticeable in the muscles used to move the eye, muscles used for chewing, swallowing, speaking, and breathing. 90% of myasthenia gravis cases include the eyelid muscles or extraocular muscles. In most cases, one of the first noticeable symptoms is weakness of the eye muscles. If the respiratory muscles become involved, death from respiratory insufficiency or arrest is possible. Diagnosis of myasthenia gravis is made, 1, through the history and physical, in addition to the EMG or electromyogram. This may show a decreased response to repeated stimulation of the hand muscles, indicating fatigue. Another test that is done is known as the tensilon test. With the tensilon test, muscle tone is markedly improved within 1 minute of the injection of a medication known as tensilon, which is an IV anticholinesterase agent, and the muscle tone remains improved for about 4 to 5 minutes. When the tensilon test is considered positive, it's noted that the muscle contractility improves for that brief period of time. In regards to the medical treatment of myasthenia gravis, the primary pharmacological treatment is the anticholinesterase drugs. These drugs work to increase the muscle contractility. It's very important that their timing of administration is done in conjunction with periods when those particular muscles are most likely to be used excessively. For example, generally speaking, the anticholinesterase medication is recommended to be administered 30 minutes prior to mealtime to improve their muscle strength and their ability to consume the meal. Corticosteroids also may be used if they do incorporate corticosteroid treatment into the overall collaborative care. They'll use what they call alternate day corticosteroid therapy. So this means that they only take it every other day. What this does is it reduces the side effects of the corticosteroids while maintaining the effectiveness of the drug. Another option for treatment is a thymectomy. The reason for this is because they found that in patients with myasthenia gravis, over 75% have abnormal or retained thymic tissue. The thymus gland is a structure that's responsible for the production of antibodies, and generally it begins to grow at birth and continues until puberty, and after that point it shrinks in size and is no longer a functioning structure. However, as I just mentioned, what they find is generally in the majority of patients with myasthenia gravis, they've actually continued to have functioning thymus gland tissue. Another option is plasmapheresis that can be done to remove the excess antibodies from the blood. And nursing interventions for the myasthenia gravis patient would consist of monitoring very closely for any potential problems with breathing or hypoxia, turning and repositioning the patient if they're having immobility problems, utilizing a soft diet and small meals to preserve strength. Another factor to note with myasthenia gravis is what is known as the myasthenia or cholinergic crisis. A myasthenic crisis is considered an emergency situation where there is acute exacerbation of muscle weakness. The same symptomatic presentation can exist with the cholinergic crisis as well. With this sudden exacerbation of muscle weakness, the patient is at risk for respiratory arrest because they will have sudden difficulty swallowing and breathing. The difference between the myasthenic crisis and the cholinergic crisis is simply has to do with the patient's medication. With the myasthenic crisis, the patient has not taken enough of their medication, and with the cholinergic crisis, they've taken too much of their medication. So a primary consideration or priority consideration here is going to be to take action in order to maintain a patent airway while determining the actual cause of the crisis. So in order to determine whether they have a myasthenic or a cholinergic crisis, they're going to use the tensilon test, as mentioned with the diagnosis. And so what they do is after administration of the tensilon, if there is a rapid improvement in the muscle strength, just as seen with diagnosis, then what they have is a myasthenic crisis and the patient needs some additional medication. If with the tensilon test, there is no improvement in the muscle tone, then the patient is experiencing a cholinergic crisis, in which case they have too much medication on board, and the focus would just be on maintaining adequate ventilation, possibly even temporarily the use of mechanical ventilation to maintain adequate oxygenation and their airway until the medications have time to metabolize and be excreted from the system. A couple of other final progressive degenerative neurological conditions that we want to touch on are Huntington's disease and amyotrophic lateral sclerosis. First, let's take a look at Huntington's disease. This is an inherited degenerative neurological disorder. Patients must actually inherit this disease and the genes that cause Huntington's from their family. Family members can be tested to find out if they will or will not acquire the disease if they have a family history. Antenatal testing can also be done during pregnancy to determine if the offspring will have the disease as well. The offspring of a person with Huntington's traits has a 50% risk of inheriting it themselves. Huntington's disease characteristics usually begin in the middle adulthood phase with abnormal movements, emotional disturbances, and sharp intellectual decline. Symptoms progress very steadily. Increasing disability and death occur within about 15 to 20 years. One of the hallmark symptoms of Huntington's disease is known as chorea. Chorea is a term for abnormal and excessive involuntary movements. It can be writhing or twisting movements of the face, the limbs, and the body, and this will worsen as the disease progresses. These movements greatly increase the caloric requirements of the patient, and patients with advanced Huntington's can require as much as 4,000 to 5,000 calories per day. ALS is a disease where the motor neurons are affected. This is a progressive neurological disorder as well that for the most part leads to death in an average about 2 to 6 years after diagnosis. The cause of ALS is unknown. There is some linking it to a history of a trauma or illness. The motor neurons in the brainstem and the spinal cord gradually degenerate to the point that the signals are not transmitted to and from the brain. There is no specific diagnosis that can be a diagnostic test that can be used for ALS, so it's primarily based on the symptoms that are presenting that the physician observes in the patient and a series of tests to rule out any other possible disease. Neurological examinations with ALS are done at regular intervals to assess whether the symptoms of muscle weakness, atrophy of the muscles, hyperreflexia, and spasticity are getting progressively worse. We're not going to see any improvement in the symptoms associated with ALS, and so their main focus is really just looking at how fast the deterioration takes place. Generally, ALS begins with weakness of the voluntary muscles, usually of the upper extremities, such as the hands. The patient will then experience dysarthria and dysphagia. The dysphagia will cause them problems with difficulty swallowing and speaking. Eventually, as the disease progresses, they'll begin to have problems with their respiratory muscles as well. Their respirations will become shallow. They'll begin to have difficulty clearing their airway of pulmonary secretions. And primary cause of death generally results from aspiration, some type of respiratory infection, or respiratory failure. The patients usually do experience complete paralysis of their voluntary muscles. Other symptoms that patients with ALS may have include pain, problems with sleep, spasticity, drooling. Depression is a common problem with ALS as well, constipation, and problems with esophageal reflux. While some patients do experience some degree of cognitive decline with ALS, one thing to note about this disease, in contrast with Huntington's, is for the most part, patients with ALS remain intellectually intact, and a large majority of ALS patients actually also maintain a normal cognition as well. We do have some medications coming out that can help slow the progression of ALS. Riluzole is one of those medications that has been recently approved to be administered to ALS patients, and it has been shown to effectively, again, slow down the progression of the disease. It can't stop it, it can't turn it around, but it can at least slow down the progression of the symptoms and give the patients a little bit longer, higher quality of life. For both of these diseases, the main focus is on the medical and the nursing care being supportive because there is no cure for either one. A major focus is going to be on monitoring the respiratory status, suctioning the patients as needed, turning, coughing, deep breathing, using chest physiotherapy and oxygen when necessary. Using both active and passive range of motion on the patient, certainly getting them to do active range of motion as much as they possibly can until the symptoms progress to the point that they're unable, and then passive range of motion, keeping their head of the bed elevated during meals to prevent aspiration, altering the texture of their meals to enable them to swallow more effectively. Eventually, they're possibly going to need a feeding tube. There's going to be, with the ALS patient, there's going to need to be some sort of alternative means of communication provided, again, as that disease progresses, because they're going to be unable to verbally communicate with you. The Huntington's patient is not as likely to have problems with actual muscle strength and ability to communicate. It's their intellectual and cognitive decline that's going to interfere with their communication ability. Skin inspections, possibly with both turning and repositioning, again, especially with that ALS patient who's eventually going to have complete paralysis of their voluntary muscles. And in both disease processes, emotional support to the patient and the family is very important.